So, yeah, you just. That's it.
Good morning, everybody. We're gonna get started here in just a couple minutes, so let everybody know.
Zero left. That is.
Hey, good morning, everybody. Welcome to October. It says August 12th, but it's actually October. And I just now noticed I don't have to fix that before I print these off. There. So our first presenter is gonna be Brooke Thomas. She's gonna do our STEM report today. Thanks.
Good morning. So the first case we're going to review, this is a Park County EMS patient. He was actually working outside of South Vermillion and had some chest pain that took him to his knees, but then he said he felt better. Bob was going to call 911. He didn't. Then he ended up having more chest pain and pretty much passed out. So they called 911. He was responding to verbal stimuli, but he was like rolling his eyes in the back of his head. So they did an EKG on scene. It obviously showed a STEMI. They called the alert into the ED. Aspirin and fentanyl were given prior to arrival. They ended up doing another EKG when he got to the ED to confirm. Heart cath showed that he had 100% thrombotic occlusion in his RCA. He ended up going to the ICU and discharged 2 days later and did very well. So here's your run history. First call to first medical contact to EKG. Everything looks really great. He had a first medical contact to balloon time of 70 minutes. So everyone did a great job here. There is his EKG. And you can see the totally occluded RCA and then successful stenting. So he had a nice little blockage there. He ended up, I guess there was an issue with the EKG transmitting. It didn't really cause any kind of delay. They went ahead and activated the cath lab prior to arrival based on the EMS report. So that saved us some time. He was discharged, goal-driven medical therapy. He participated in cardiac rehab. Next case, this was a 71-year-old female. She had known coronary artery disease and actually knew that she needed a cabbage, but out of fear, she had not yet scheduled her surgery. And it looked to be several months where she was waiting. She was actually seeing her cardiologist at Providence. She had a cardiac arrest in the office. The office staff initiated that.
You're gonna go down. That's not a bad spot.
Have a better place. Anyway, they initiated ACLS there, called 911. Terre Haute Fire came in, took over. She required a defibrillation when she got there, compressions, the whole 9 yards. They did intubate her on the scene. EKG showed the ST elevation and the alert was called ahead. The patient actually coded again in the ER once she got here. So they did end up activating cath lab. Cardiology was consulted. They also called cardiothoracic surgery, just knowing that she had the known multivessel disease. They did end up just doing PTCA of this left circumflex, and they had to insert a balloon pump. She was in cardiogenic shock. When she got to ICU, she was pretty sick. She was in cardiogenic shock on all the pressors. Prognosis looked pretty poor. She did end up recovering. 3 days later, they took the balloon pump out. They extubated her. She started working with PT and OT. She was on 2 liters nasal cannula. They did have some issues with respiratory issues. She had a UTI. She also had a dental infection. I had plans for cabbage in the next 7 to 10 days after that, once her care was optimized. Unfortunately, I reviewed and she did pass away before she could have the surgery. But, you know, it just happens, you know, there's not much we can do about it, but she did have, you know, a good recovery after the initial stimming. So here's your numbers. Excuse me. The call to first medical contacts was 6. First medical contact to EKG was 17. Obviously, she had cardiac arrest. So all of these are non-system delays. Transport time 7 minutes. Call to the arrival was 38. First medical contact to balloon was extended. Our goal there is 120 minutes. 6. And then the ED door to balloon was 111. So not too far off our goal, but again, non-system delays that are unavoidable. So there's her EKG. You can see, I mean, you can tell on her cath over here, even though the circumflex, you can see she's got pretty significant disease. They did balloon it and opened up the culprit lesion. Unfortunately, I think her disease was just too far gone. So the cardiac arrest obviously resulted in the non-system delays, which are acceptable delays according to the ACC. The medical office did act promptly, which allowed the Terre Haute Fire Department to come in and expedite care. So great teamwork on that side. And really door to perfusion was 111 minutes, which is not extraordinarily bad for all the things that happened for her. So thank you.
Thanks, bro. Thank you very much. We're gonna be up next with our stroke reports from Beth Harrison, our stroke coordinator. Well, we all know that. I pushed the button a couple times. It actually worked, but I'm still making it. Go about 30 times, 30 slides when you hit the button, so.
I'm technology. Good morning. This is a case from our Terre Haute Hospital.
Yeah, other.
Yeah. Here we go. See, I told you. This case was a 58-year-old male. He lived independently. He did have prior medical history of CAD, hypertension, high lipids, smoking, alcohol use, cardiomyopathy, pancreatic disease, and popliteal artery thrombosis. He did have a prior stroke and from a left apical thrombus. He was on multiple home meds, including Plavix, which he was not compliant with any of his treatments. EMS was called for unresponsiveness. Upon arrival, they found the patient lying in bed with his girlfriend at the bedside. The patient had been fine and talking to family 10 to 15 minutes prior and suddenly grasped the mattress and slumped over. He had just been seen at another ER, not Union, the day prior for complaints of leg pain, which had been ongoing for several weeks. He had a scan 3 weeks prior, which was negative for a DVT. He was to have a specialized scan in me that morning, but did not keep the appointment. But EMS did do an exam of his left lower extremity and it was found normal. He was exhibiting aphasia, right-sided facial droop, right-sided weakness, and inability to follow any commands. And he also had some neglect. Cardiac monitor showed sinus rhythm, GCS was 9, blood glucose 100, BP 142/90, pulse 72. Everything else was good. I did start an IV to his left forearm. Cincinnati pre-hospital stroke scale was positive. He was VAN positive, and a stroke alert was called to the ER via IHERN en route. And like I said, he was not compliant with anything. Here's your run times. EMS was notified at 1926, dispatched at 26, and routed at 27, on scene at 28, and outpatient at 1929. They departed scene at 1945, arrived at the ER at 2012, and I did not see a patient transferred. In the emergency room, he went directly to CT1 per EMS card. His last known well was established at 1915. When he arrived, his NIH was 17. He did a CT stroke at 2008 and was negative for a bleed. It did show some significant old lacunar and cerebellar infarcts. Teleneuro was consulted, TMK was advised, and he was administered the TMK at 2028 with a door to needle time of 30 minutes, which means our metrics. I did do a CTA at 2142, which showed the M2 segment of the MCA was occluded. And there was perfusion defects all throughout the distribution area of the MCA. And he also had a complex calcium plaque in his left internal carotid. He was transferred to Indianapolis via air for an evaluation and treatment of an LVO, and there is no further follow-ups in the EMR, which usually you see them coming back into the system. So I don't believe this gentleman had a good outcome. Really good strengths of this. The Cincinnati pre-hospital stroke scale was completed, vein was completed, and the stroke alert was called. The patient received optimal care for his condition from both EMS and ER. But he just was not a very good candidate, and he was highly intoxicated at the time he came into the ER. Here is our Union Hospital Clinton stroke report. And this was a 31-year-old female. She was independent. Her only prior medical history was a chole and a partial hysterectomy, and she was on no scheduled home medications. EMS was dispatched to a private residence from a fall from a vehicle and weakness. Fire was the first to arrive, and they reported the patient was lying on the ground next to a pickup and was unresponsive and barely breathing, but had a bounding pulse. Patient awakened with a sternal rub, was able to answer yes or no questions with a squeeze of her right hand, and rebreather was applied per fire. EMS arrived, and by that time the patient was vocal. C-collar was applied and spinal stabilization, because they did not know the mechanism of injury. She was assessed for bruising and deformities, but none were found. She was flaccid on the left side and is unable to feel touch on the left side when EMS arrived to their assessment. Her EKG showed sinus. Her GCS was routine. Her blood glucose was 65, and D10 was started wide open. And when they did that, patient did become more alert. It was rechecked at 77. They said after a total of 75 was given. And I do see where it was rechecked when she got to ER, and it was 120, 128, I believe. But she was complaining of a severe headache. 20 gauge was to the right AC. Her blood pressure was fine, respirations were fine, SAT was fine. Her pre-hospital stroke scale was positive. Her vein was completed, and stroke alert was called to Clinton via IHERN at 1845. Here's our run times. EMS was notified at 1811, dispatched 1813, and route 1814, on scene at 1826, and outpatient at 1828. They left the scene at 1836, arrived in the ER at 1850, and patient was transferred at 1855. In the emergency room, she went directly to CT. Our last known well was established at 1800. At that time, her NIH stroke scale was 11. CT stroke was completed at 1859 and was negative for a bleed. Teleneuro was consulted and TNK was advised. Her TNK was administered at 19 or a needle time of 19 minutes, which is phenomenal work. CT of the spine was negative. CTA was negative for an LVO. Patient did have a CTA repeated at 2024 due to complaints of right temporal pain, and they were checking for like a hemorrhagic conversion after the TNK, and it was negative. She was transferred to Union Terre Haute at 2145. During her course of treatment here, the MRI was completed, it was negative for a CBA. She was discharged home with a diagnosis of complicated migraine. But even though it was a migraine, everything was done correctly on that patient, because at 31 years old, could have had a CBA. So there was some excellent work and execution on the care of this patient. And luckily she had a good outcome. So thank you. I mean, I think EMS did a really good job with this one. Excellent narrative documentation by EMS on this case. It really told the story, what was going on. The stroke alert was called. We followed the stroke protocol all the way through, and we had some excellent door to needle times. So good job, everyone.
You might have any questions for Beth? Thank you very much. Next up is Tina. She's gonna do our trauma report.
Good morning. I gotta check my times, since I messed up my times and Barry wouldn't let me fix them, so.
I've already sent it off.
I did already send it out. All right, so this was a crazy case. A 42-year-old male, it was an industrial accident, it was a crush injury. Let's see, so the 911, don't pay attention to those things. 911 call came at 6:06, dispatch 6:08. They were en route at 6:09. On scene 6:12, departed at 6:29, and at Union ER at 6:32. So call dispatch was 2 minutes, and dispatch to en route was 1 minute, en route to arrival was 3, on scene for 17 minutes. Departure to arrival Union ER was 3 minutes, and 911 call to arrival was 26 minutes. That's a lot. Dispatch for an industrial accident. This was the EMS report. On arrival, they found the patient lying on his right side on the floor, next to a large roll of plastic material. Staff members were at his side. They were transporting this huge roll of plastic. They said weighing at 1,500, 2,000 pounds on a cart, rolled off. As it hit the patient in the middle of his back and rolled across his upper back. So on the scene, he was listening, greeted EMS, was talking to him. Blood noted in and around his mouth. He didn't have any loose teeth. The airway was patent, he had shallow breaths. Lung sounds were decreasing, and the left lung, his right was clear. No obvious external bleeding that they could see. He had major swelling of his neck and shoulders with right tracheal deviation, so they couldn't apply a C-color. He had a right shoulder deformity with his arm bent at a 90-degree angle at the elbow. His palm was up and raised towards his head, and I can't figure out kind of how that was. His left leg was bent at the knee at a 45-degree angle and his foot on the ground. I'm thinking that probably wasn't a good thing either. Trauma alert was called to Union ER. Secondary assessment, he had a large contusion, major swelling across the anterior and axillary portions of his chest. His chest appeared distended. Left breath sounds were decreased, but he had so much swelling in his chest, they couldn't find landmarks and ribs to do a needle lead compression. They did vitals, 12 lead, started an IV, gave him fentanyl and Zofran. Blood pressure 113/75, his heart rate was 150. Rests were 30, SAT was 82, GCS was 15. They gave an update to Union on the IHERN and urgent emergent transport to Union ER. So the pre-arrival said, roll fall on mid-back, questionable hemorrhage, right shoulder and hip pain. Pulse was 144, SAT was 74, and room air, it was 86 with a non-rebreather. So this is our criteria. So he met because of the respiratory distress and crush injury for level 1. Level 1 was called, activated at 6:25. ER physician was notified at 6:25. Arrived 6:36, and trauma surgeon at 6:38. So the our physician was at the bedside on arrival. Industrial accident, 1,000-pound plus roll, fell off a cart, rolled on the patient. He had right hip and shoulder pain, shortness of breath, chest pain. Breath sounds were diminished on the left, and he had a right shoulder deformity. He was alert and oriented on arrival. GCS was 15. He was dusky and obvious distress, heart rate 142, breath 23, blood pressure 128/115. Chest x-ray showed extensive subacute emphysema. At 6:46, they intubated the patient because of his neck. Had moderate blood noted in the oropharynx, and his end-tidal was 27. So the surgeon, when he got there, they did a phasic thoracostomy. He had multiple rib fractures that they could feel. Bilateral chest tubes were placed by the trauma surgeon and the ER doc. He got dusky, lost his pulses. CPR was initiated at 6:51. He got 2 doses of epi. They ended up doing an open left thoracotomy while they were doing CPR. Had obvious air noted in the pericardium. They gave 2 units of blood at 6:58. The pericardium, and once they started the blood, they got Ross back at 6:58. Pericardium was incised at 7:06. They said there was a big old rush of air out when they opened it up. MTP was started at 7:06. They placed a right trauma line and a femoral line, and left femoral C line was placed. They put in a left art line. He was too unstable for CT, so they did another chest X-ray, and I'll show you these in a moment. Had bilateral lung expansions. So in the meantime, when all this was going on, it was all happening at once. A helicopter came in to get another patient, apparently, but they had only had a pulse back on this guy for about 10 minutes and were concerned because they hadn't really looked at his belly. So the decision was made they would take him to ER. So they released that helicopter and called for a second one. So that's the end of that. So they went to the second helicopter came. They went to OR with the patient. So his ER diagnosis: crush injury, traumatic arrest, pneumopericardium, pneumothorax, left lung lacerations, bilateral extensive rib fractures, pericardial tamponade, acute respiratory failure. So he was taken to OR for an exploratory lap and exploration of the ER thoracotomy. The lap was negative. How, I don't know. This is amazing. Small laceration to the left posterior lung. They repaired that with staples. They placed a JP, put 2 large bore chest tubes in on the left, and the right, that's supposed to be chest tube, remained in place. Cardiac window remained open. So he was transferred to IU Methodist via air. They sent 2 units of blood with the patient. So these were his labs. White count was okay, really. Hemoglobin wasn't too bad. Hematocrit A&R was 1.04. Sodium and all that was pretty much okay. Trope was 298. Lactate 4.8. And alcohol was negative. They did type and screen. They gave him the 2 units, and he ended up having 2 rounds of MTP. ABGs post-op 7.35. PCO2 was 40.7. PO2 76. Base excess was -3, and SAT was 93. So his imaging, the first one that they did showed a widening of the superior mediastinum. And so they were questioning whether there was a mediastinal hematoma. He had multiple left-sided rib fractures and possible small left pneumothorax. This was the one that was done on arrival. They couldn't confirm it because of the and he had mediastinum that they could see with possible component of the pericardium, patchopacities on the right upper lung, and multifocal opacities through the left lung, suspicious for pulmonary contusion. Inferior displacement of the right humeral head relative to the glenoid. So he had an anterior shoulder dislocation, and they suspected a fracture of the humeral head and neck and displaced fracture fragments and something. So this was the first chest X-ray, and I went back to look at these to make sure I put them in order. So this was the first one that they did. And I'm not real good at reading these. Can you see the mediastinal widening, Dr. Jackson?
Oh, yeah, so if you're following his trachea, which appears to be midline here, that whole white area above the heart is his mediastinum. It's much better than it's supposed to be.
Okay, thank you. So the second chest X-ray they did after the chest tube placement in ER and the thoracotomy showed the placement of the tube and then the interval placement of the right side chest tube. Didn't see appreciable pneumothorax on either the right or the left. Increased opacity of the middle upper left lung field. Could be external to the patient or represent contusion hemorrhage. Okay. Extensive subcutaneous emphysema, acute left side rib fractures, and mildly displaced midclavicular fracture. This was after the second chest X-ray that was done in ER. And like I said, I'm not good at this, but to me, this looked worse than the first one. So that's why I went back and if I printed them out with the dates and times, because I'm like, that can't be right, because I'm like, man, I really jacked this up. So I went back and looked, and this is actually the second one.
This is after the
So
thoracotomy.
is that the swelling in the air?
The air.
Yeah,
Yeah,
so the first one was done at 6:48. This one was done,
this is post thoracotomy, right?
yeah.
Yeah, see
Oh.
Yeah, this was with
I see all
the,
that.
after the ET tube, the chest tube and the thoracotomy in the ER. What do you think of that?
I see the hair.
It looks terrible, but.
Okay, so I'm not crazy, it actually looks worse.
No, yeah, it looks worse. There's a lot, it seems like the subcutaneous air is more
Much worse.
pronounced.
Which you did say that, didn't it? You
Yeah,
read that.
it did,
Yeah.
yeah. But I,
But this is post intubation as well.
yes,
And so you're gonna be putting a lot of positive pressure into
right.
the lung and whatever lung injury, and that's gonna be ballooning every other tissue.
Yeah, and I think the ER doctor did kind of mention, there was so much in this chart, I just couldn't put everything in here for the presentation.
Great
But I think
case.
he did mention that he thought that was actually what caused the arrest was the positive pressure from being intubated in the vent.
It's
So,
possible.
yeah, I mean, that was just a theory on his part, but I'm like, I can see it. Oh, yeah.
Yeah, hindsight, I mean, they did the right thing. Airway
Oh,
first.
absolutely, absolutely, yeah, they didn't have a choice.
Yeah.
Yeah. So this was an X-ray of the pelvis that showed, traumatic, fractures and, widening of the SI joint, outward rotation, left hemipelvis, compared to the right. No definite fractures. Large bore right common femoral vein line and, left common iliac vein. So the post-op chest X-ray, and I should put it in here, but it really didn't look a whole lot different from that second one. Right chest tube in similar position, interval placement of the left chest tubes. Near the superior left hemothorax. Skin staples, they put an OG down. And then the ET tube showed that. And then post-op KUB showed left and right femoral lines. So the post-op diagnosis, crush injury, traumatic arrest, pneumopericardium, pneumothorax, left lung lacerations, since rib fractures, pericardial tamponade, and acute respiratory failure. And that's just a review. So just so you know what we do when we're sitting back here staring at our computer. Oops, wait a minute. Let's get back up here. These are the guidelines minus 2 or 3 that I left out for this patient. So when we do these patient reviews, we start from the time of the 911 call, go all the way through to the minute they leave. So these are all the guidelines, plus a few others. So not only are we looking at documenting, everything that was done, but did we meet these guidelines? So we go through every one of these guidelines. Did we follow it? Did we do what we're supposed to do? These are the guidelines for just that one patient. So this is what we're doing when we're sitting back there.
We go back one slide, Tina.
Yeah.
Oh, too far.
You want to see the image? There you go.
No, I want to see the diagnosis.
What's diagnosed?
Keep going forward. There you go.
Right there.
No. You just did there was just a slide of a bunch of diagnoses, Methodist diagnoses.
Oh, it's after,
she'll
it's
get to
not
that.
there yet.
She's.
Oh,
Yeah, but
Too far, oh, okay.
She hit the button, she hit the
I-
button.
Okay.
I was like, no, go back.
All right, so that's all of our guidelines. It's a little there. Is that what you're looking for? All right, so this, I got some notes from, I think his first follow-up visit. So I don't actually, I kind of wanted to see how he progressed at Methodist, but sometimes getting follow-up is a little difficult. But I did have notes that they sent to the doctor's office. So this is where I got this too. This is actually from Methodist. So he had bilateral pneumothorax, right hemothorax, pulmonary contusion. He had aspirated. He had left rib fractures 3 through 10, right rib fractures 5 through 6, right humerus fracture, sternal body fracture, left clavicle fracture, left T10 transverse process fracture, grade 5 liver laceration, right iliac bone fracture, pelvic ring fracture, lip laceration, grade 1. I looked that up and I can't remember. What is that?
BIFFL.
Yeah. I looked it up, but I don't remember what it was. Bilateral, it's a cervical. Something or other.
I don't know.
I can't remember what it was. I have to look it up. E. coli pneumonia, he ended up with ARDS, respiratory failure, hemorrhagic shock, PE, dislocation of right shoulder joint, rhabdo, traumatic encephalopathy, and the SI joint dislocation. So this is kind of what I wanted the notes from Methodist, so I could kind of see what happened, what they I might get it later. If I get it, I can follow up next time. So anyhow, he did get discharged, back on the 14th of September. I thought it was actually pretty good for all the injuries he had. He is at home, he's moving around some, but he's still having, like, as you can imagine, severe pain. I don't know how well he'll ever get to walk again, but time will tell. But he's just, I think, very, very lucky to be alive. And I think everybody did a wonderful, wonderful job. And I think we're the only reason he survived, so.
That's a very, very interesting case.
Yeah,
I-
yeah.
It's, I think my whole career, I've never seen a tamponade from a pneumopericardium.
Really?
So that's interesting.
Yeah.
That refers to a cerebral vascular injury. Just looked it up. Thanks, Tina. Anybody else have any questions or comments?
Cerebral vascular.
I just wanna say, like, this is why we take trauma patients to trauma centers, because I need gone to a hospital,
Look
and
at
have a trauma surgeon there to do that open thoracotomy,
It
and
was, but I
Arterial
think it
window,
was the smash.
you'd have been dead in the ER.
Remember for
But yeah, that saved it.
100%.
Definitely. That makes sense.
Yes.
All right, next up, OP emergencies with Dr. Abernathy.
Sure. You have an attendance roster for this meeting.
Yeah, I sure
Or
do.
did you have one?
Yeah.
Okay, thank you.
We have a sign-in sheet up here, and plus I'll add the people that are online also.
Thank you.
We're using the arrows on the keypad. Yeah, it's a lot easier than the clicker, because if you hit the clicker, sometimes it goes like 10 slides. So.
Great, sounds good, wonderful, thank you all for being here. I'm kind of new here, I can turn this around, right?
Do whatever you like.
Sorry. Who am I talking to? Are you nervous? I want to know Dr. Jack. Somebody has a fireman shirt.
Paramedics, EMTs, nurses, doctors,
Okay, so the whole gamut.
the whole.
Everyone's-
Yes, ma'am.
Well,
Yeah, I gave you the one.
I just call this tag.
Hi, Risco B. I think I talked to Dr. Jackson. I may have talked to a few of you recently, but I'm Mary Abernathy and I appreciate you being here. All right, so I don't really like to give lectures. Person will tell you, I don't like people to listen to me. Anyhow,
She's so good at it.
what I hope to you get out of this presentation, and I have like 20 minutes.
Yeah, but as long as you want.
Oh.
We
Please
will never
stop.
limit you.
Just go, whoop. I don't care. Yes. So I also, in addition to working here, I also chair the Indiana Maternal Mortality Review Committee. And so we review all the maternal deaths. We try to do year for year. So I think we're on 24 years. And we hope to have that done by maybe March, April. And so I'm gonna pull a little bit of that information into my discussion as well. We're gonna review the major causes of maternal mortality. We're also gonna talk about what common OB emergencies, and you know them already, you've seen them, right? This isn't your first day on the job for most of you, I'm guessing. That EMS clinicians can encounter pre-hospital. And there are some guidelines that have been put out by your organizations and our organization, ACOG, American College of OBGYN. Those are in the handouts, and those are most of my slides. So I didn't want you to be writing stuff down. So we wanted to give you the handouts for them and to review some treatment algorithms and what are key and important. And most importantly, to probably open the dialogue. I probably haven't met any of you except for Dr. Jackson. I don't even know what you carry on your ambulances, what drugs you carry. And so I may say a drug here and you go, you don't carry that, sister. So that's kind of what I wanted to at least open the dialogue for. This is what we found many times. Most of our maternal deaths have had some interaction with a provider. And that's usually not the OB provider, although it could be. It's usually one of you all's providers. And they've had an interaction with that. And so what we have to do is to get more comfortable in communicating what's really going on here. And our pregnant patients, they act differently than the non-pregnant patients. So if you see a blood pressure of say 150 over 110, you're probably like, I saw 5 of those yesterday, right? That's not good for us. We have fragile little vessels in the brain. And so we worry about that more. So we're more kind of anticipatory when we see elevation of the blood pressure. And so again, it's kind of like getting to talk to each other about what are those common things you see. So this is the Indiana Pregnancy Associated, sorry you can't see it, but it's the Pregnancy Associated deaths, the causes. So pregnancy associated is the whole pie. Pregnancy associated they could be due to pregnancy related, meaning due to a cause or complication due to a direct pregnancy caused by the pregnancy, not related to the pregnancy, or undetermined or unable to determine. And so if we look at the whole pie, unfortunately, and you know this better than I do, overdose is the overwhelming cause of all of our maternal deaths. It usually takes up about a third. This is the 5-year data the state just released. And if you want a copy of that, I made a few copies of that. The state was very delinquent. I guess it's too busy dealing with the COVID. Now, unfortunately, overdose, you know this better than I do. If you combine homicide and suicide, which I frequently do, that usually takes up about 20% of our deaths. So between overdose, homicide, and suicide, that takes up roughly about 50% of your deaths. The ones we tend to focus on are the pregnancy-related deaths. These are the pregnancy-related deaths. Cardiovascular conditions and hemorrhage account for 1 and 2, and it vacillates depending on the year, but in the overall data, they were, neck and neck. And when you look at the causes of cardiovascular condition, it's some form of cardiomyopathy, whether she got it before she delivered or it was discovered after she delivered. Hemorrhage, unfortunately, and you'll see this in a minute, ruptured ectopic pregnancy. Most of the time, those women are found down at home, and you all are picking them up. They may or may not even have known that they were pregnant. Usually somebody knew they were pregnant, but hadn't been to a doctor yet. So those are leading causes, and we're going to talk about common things you may see related to those. And then infection, overdose, and amniotic fluid embolism. You're probably not going to see amniotic fluid embolism, but you might. Tends to happen mostly on labor and delivery. It doesn't usually happen at home or in the field. It's an anaphylactic reaction when there's some mixture of fetal amniotic fluid or fetal squames into the maternal circulation, causes a massive anaphylactic reaction, DIC, and total cardiopulmonary collapse. The only way a patient's going to survive an AFE is if they have very good rapid onset cardiopulmonary resuscitation. So that will involve you sometimes. But there's not a lot at this point that we can do we can prepare for it. But that's unfortunately one of the higher causes of death in our state, which is not different from any other. So I'm going to quickly go over these because I don't like to talk too much. We're going to talk about eclampsia. We're going to talk about what to do if you see severely elevated blood pressures and what blood pressures are elevated for us. Cardiovascular disease and hemorrhage, which we just showed, are the 2 leading causes of pregnancy-related death. When we look at eclampsia, and this is why if you're like me, you can't probably see that very well. I put it in your thing. Eclampsia, probably the most important thing you need to get out of this talk is to ask every woman, are you pregnant or have you been pregnant within the last 6 weeks or 12 months, depending on kind of what's going on. Because that's going to help you form that differential diagnosis of what possibly might be. Eclampsia, she's not going to have eclampsia written on her forehead. She's going to have a seizure. You're going to get called to respond to someone who has a seizure. And if they're pregnant, especially if they're more than 20 weeks, you should probably treat it as eclampsia until some OB says, no, it's not eclampsia, but sure, she's got seizure disorder. But I would presume it's eclampsia until somebody says it's not. With eclampsia, the first thing we're going to do is administer magnesium sulfate. Do you carry magnesium sulfate on your ambulance? What dose do you carry it in?
Uh,
Grams?
4 grams, yeah.
4 gra- okay.
Yeah.
Excellent. I didn't even think you'd have it. Okay. All right. So magnesium sulfate, you can give it intramuscular. It really hurts. Yeah. So
Yeah.
usually put it,
All right.
put it in IV fluids, 4 to 6 grams IV over 20 minutes. Now, if you give it IM, obviously you're not giving it over 20 minutes. I usually, until you know what their creatinine is for preeclampsia, I'd start with 4. You're not gonna go wrong with 4. So 4 grams IV, calm the patient down. Obviously, the most important thing is to any seizure patient is protect their airway. Roll them on their side if you can, try, to make sure they don't aspirate, get their vitals. And then first line of therapy is starting that magnesium sulfate. Hopefully getting in over 20 minutes, you can get any patient to the hospital within 20 to 30 minutes, usually, I'll ballpark it. So you're not even gonna have to worry about the maintenance dose. Say she doesn't have good renal function, because sometimes those poorly controlled diabetes, I've got renal disease as well, and I develop preeclampsia, and oh, by the way, I'm gonna go on to develop eclampsia. They walk hand in hand. You're probably not gonna go wrong with giving an anuric patient 4 grams, but you're not gonna give her a maintenance dose, because that 4 grams, since magnesium is renally eliminated, that's gonna stay around for a while, and that's how we even dose it in somebody who is anuric or has poor renal function. We'll give them some mag, because usually as fast as we put it in, if they have good renal function, they're peeing it out. So that's why we have to give it as a continuous IV. If somebody has poor renal function, we give them a bolus, check mag levels. When it goes down, give them another bolus, and that's how we deal with it. So you're even if a patient has poor renal function, you're in the ambulance or whatever, you're not gonna go wrong by giving her 4 grams of magnesium sulfate if she's seizing, and most importantly, if she's pregnant. Now, if she doesn't look pregnant, somebody said, well, we think she might be 6 or 8 weeks, it's probably not gonna be eclampsia. So I don't know necessarily that I would recommend giving magnesium for that. But if she's clearly pregnant, has a seizure, we would recommend starting with magnesium sulfate. Now I know you can't read this. So if she keeps seizing, because obviously you want her to stop seizing, you can use various benzodiazepines, Ativan, Valium. You can use those. You can even use a little Versed. Obviously, when you do that, you've got to be very, very cautious and know their airway may go south fairly quickly, and you're going to have to deal with that too. But hopefully, by the time you get the magnesium on board, you're in the ER, and Dr. Jackson's taking care of them, and his best bet is to go.
Yeah.
Right there. There's a big hallway. So that's probably what you need to know. You can use Ativan, you can use Valium, you can use Versed, but obviously you're gonna have to really protect that airway if you do. And then once the resolution of the seizure, we're gonna monitor her magnesium levels. We're gonna try to obtain a head CT because maybe she had a bleed and that caused her to have the seizure. So you're gonna usually do that as well. You're gonna evaluate, make sure she doesn't have other signs of preeclampsia, or if she does, we're gonna do it. And then there's other kind of information in here, what to do if you've gotten too much magnesium on board. You can give calcium gluconate. So it's kind of mostly just running the algorithm to figure it out, but hopefully you will have gotten the patient to labor and delivery, and the fine folks in the back of the room know what to do if they get to that point. Any questions? So the next thing we're going to talk about is severe elevation of the blood pressure. And again, this is something that can happen up to 6 weeks postpartum. And that's, if I get one thing across, that's one of the big things that I want to do is say, our blood pressure criteria are much different than probably you when you see a 70-year-old who runs 160 all the time. That's not what our pregnant women should be running. The pregnancy hormones normally cause vasodilation, vasorelaxation. So even people who have high blood pressure who are pregnant early in pregnancy, they have the best blood pressure control early in pregnancy because they've had that nice progesterone vasodilation. And they're like, I don't need any blood pressure medicine. Everything looks good. They get about 24, 25, 28 weeks, and all of a sudden things go back up to normal. And you're like, yeah, you do need the medicine. Should have been on it the whole time. So again, the key question here is, are you pregnant or have you been pregnant in the last 6 weeks? Because somebody's gonna call the ambulance and say, she doesn't feel well, she's dizzy, she's lethargic, she doesn't feel well. You're gonna discover that her blood pressure is 160/110 or higher. That, she's not gonna call and say, I need you to come pick me up because I have high blood pressure. She's gonna predict these blood pressures. So there's a whole lot of stuff here. What I wanted you to make sure, these potential signs and symptoms. If you see a patient who is pregnant, who has elevated blood pressures, these are the things I want you to ask about. Do you have a headache? Are you seeing spots you didn't used to see? Do you have shortness of breath? Do you have epigastric pain? Anything changed about you? Those are the kind of the signs and the symptoms we need you to focus on. Labs that you're going to consider. You're going to get a CBC with platelets because you want to know if she has thrombocytopenia. You're also going to get a CMP because that's going to give you your liver function test as well as your creatinine, because you want to know. Preeclampsia is a triad of symptoms: hypertension, edema, and going into different organ systems, the liver, the heart, the kidneys, the brain. Obviously. So you're going to want to also know what your urine protein is. And this gets a little tricky. If they've already delivered, you can't always use a clean catch UA because she may have some protein in there from her vaginal discharge. But hopefully you can get a urine PC ratio or a urine dipstick. If it's 2+ or more, we know that that's significant proteinuria that our pregnant patient shouldn't have. And then if she has a severe headache or any neurological symptoms, you may want to consider a CT. So then we kind of classify it. If she just has elevated blood pressures but normal labs and no symptoms, she has gestational hypertension. The recommendations are now to get them delivered at 37 weeks. You don't need to know that. If she has preeclampsia, which means she has proteinuria, she has abnormal labs with the elevated blood pressure, we're going to manage the elevated blood pressure. We're going to decide if she has severe preeclampsia. If she has severe preeclampsia, the recommendations are to get them delivered at 34 weeks. If they just have preeclampsia with mild features, and we used to call it mild, we used to call it severe preeclampsia, we don't do that anymore. There's some academic who probably made their career on that, but anyhow. So just preeclampsia with mild features, we get delivered at 37 weeks, but we're going to bring her into the hospital, kind of monitor. And then preeclampsia with severe features, usually that's based on blood pressure criteria. We're going to treat that blood pressure. We want to keep that blood pressure less than 140/110 or over 90. And we're going to usually work towards getting her delivered. So the third thing we're going to talk about is cardiovascular disease. Unfortunately, as I said, this is one of the leading causes of our pregnancy-related deaths that we see in Indiana. Again, the key question is, are you pregnant or have you been pregnant in the last 12 months? And unfortunately, a lot of the red flags for cardiovascular disease worsening are the same pregnancy-related complaints. And so as an OB, you're kind of like, oh, is this serious shortness of breath or is this not so serious shortness of breath? Because some of you have probably been pregnant and you have almost an air hunger sometimes. You feel like you can't get that deep breath that I used to, that deep cleansing breath. And so they'll say, I'm short of breath. And what I usually do is just kind of watch and sit there and talk to them. Now, the patient I saw yesterday in the office, she was breathing like a little puppy, just sitting at rest. It's like, you get to go over to the hospital. So anyhow, so you got to kind of use a little judgment here. Nobody should ever fault you if you overcall this, because that means then you're not going to make the mistake of assuming it's nothing when it is. And unless you got an echocardiogram at the end of your fingertips, nobody can ever fault you. And I always tell clinicians, providers starting out, I would rather you over order tests until you feel like you're more comfortable that you can order less tests. So anyhow, the cardiovascular signs, shortness of breath, dyspnea on exertion, orthopnea. I had this same lady tell me yesterday, I can't sleep laying down. Ooh, okay. Tachypnea, cardia, oxygen saturation less than 94%, hearing a loud murmur, wheezing, crackles, distended neck veins. Same thing you might see in your 80-year-old that you pick up with CHF. So, but if you see that in a younger pregnant woman, those are very concerning signs. They're going to complain again of edema. A lot of pregnant women have edema, especially in the 3rd trimester. The first thing I do is I'm looking down at their blood pressure. And then I'm like saying, are you having any other problems? No, just by the end of the day. And that's very common. But again, you have to kind of discern, when is this going to be a problem I have to get worried about? And so you kind of have to take all things in consideration. Change in exercise tolerance, paroxysmal nocturnal dyspnea. She has desaturation with ambulation. If you hear a murmur, peripheral edema. So what we're going to do, first line, get your EKG, your BNP, your troponin, and a chest x-ray. And then I hope to God, unless you're totally confident that it's not a problem, you're going to get an echocardiogram. Now, sometimes getting an echocardiogram in this hospital, you have to speak with the Lord to get an echocardiogram. I'm guessing it's probably the same thing for you. Be persistent. You don't want to miss anything. Be persistent. And sometimes you get to wake Tony Nasser up or Dr. DeLuel, and you get a little crusty. And the new guy I talked to recently, you get a little pushback, and you're like, no, she has dyspnea, orthopnea. I think she really needs that echocardiogram, because I'll tell you, those echo techs, they will try everything possible to get out of doing that. Oh, I don't want to get up in the middle of the night. You're going to get up like I am already. So anyhow, so usually I would put that as your 5th component. You're going to get that echocardiogram. And if her ejection fraction is 60%, hallelujah, and everything else is fine, that's good. I feel very reassuring with that. You'll sometimes see their BNP will be a little bit elevated with preeclampsia. We don't necessarily know or do anything about that. And their troponin every now and then. We have one patient right now who was it 17 months drink she would drink in a day. And she bumped her. This was over in Iowa, Kansas, somewhere. And so she was labeled as having a heart attack. But Dr. Nambury has said, no, I think she just had some leaky enzymes. So anyhow, but start with your BNP, your troponin, get your chest x-ray, your EKG. And then hopefully the 5th thing you're going to be getting is your echocardiogram. And then treatment depends on what's really going on. And hopefully she'll be out of your hair by that time, if that makes sense. And then this just shows you the leading cause of cardiovascular disease is cardiomyopathy. By far, we will see different things. We have this new creature now, spontaneous coronary artery dissection, which is hard to diagnose unless you got the cardiology squirting dye into her vessels. You're probably not going to diagnose it, but she'll present within an MI myocardial infarction picture until they squirt some dye and they see it's not just a small little segment that's blocked, it's almost the whole artery that's blocked for a longer period of time. And we're seeing more and more of that, unfortunately. But cardiomyopathy is by far, and that can present within the last month of pregnancy, all the way out to 6 months after she's delivered, which is usually when they start calling you all. So the last one we're going to talk about is hemorrhage. And again, this is what surprised me, but this is consistent data. I would think in nowadays where you can walk into a drugstore and you can get a UPT, you get almost anything imaginable. We wouldn't have this much death due to ectopic pregnancies. Yeah, that's the leading cause of hemorrhage death in Indiana. And it's across the nation as well. And it's a very, very unfortunate. Sometimes, as I mentioned, it's only discovered on autopsy. They go in on autopsy, they find a hemiperitoneum, and then they see a ruptured side on one of the fallopian tubes. The patient may not have known about it, or she knew she was pregnant, she just hadn't seen anybody yet. But that's sad and concerning to me because of when we live and where we're living, that's still a major cause of death in our state. These things that I'm going to talk about are probably more commonly what you're going to come across, because a ruptured ectopic pregnancy, you're going to get the call found down at home.
And you're just gonna work with what's in front
And you're just going to work with what's in front of you, take her, and hopefully they'll start throwing blood products in and figure it out. Sometimes there's a little confusion there, but whatever. But this is probably most of what you're going to see. Lady delivered in the bathroom at home. You've scooped her up, you put her in an ambulance, wrapped up the baby, and she starts having profuse vaginal bleeding in your ambulance, making a big old mess, right? What can you do about it? First thing you're going to do is administer oxytocin. How do you administer it? You don't have an IV in yet. You can give an IM. 10 units IM. Do you have oxytocin?
No.
Yeah,
No, ma'am.
that's what I wondered, if you had that. Maybe we ought to consider that. How often has this happened?
Yeah.
I mean, how often has that happened where somebody starts bleeding? Usually the placenta's still inside too. You've gotten there, the baby, or you've either delivered the baby or the baby's out. You scoop her up and hopefully you fly in it, is what I would do. But if you have it, you can give 10 units IM, and then you can do gentle traction. Now, how do I describe gentle traction? It's not a pull. You just put a clamp across it. And I try to put the clamp as close to her perineum as possible, right? Just to give me a little bit more leverage, and just hold it there with just a little traction. If you need to, you can start massaging her uterus, and what you'll feel is a little bit of give and take on that cord if you've got it close to her perineum. And that's gentle traction. You don't want to pull and invert her uterus, because then you really got a bloody mess. And that's a big problem. So just gentle traction, because you don't want to pull it off either. You can firmly massage the uterus externally. It should feel like a grapefruit under the skin. Life-threatening hemorrhage, you may need to give TXA, obviously transport the patient to the hospital. And then I think this goes into a little bit more detail. Delayed or postpartum hemorrhage is after 24 hours after they deliver to up to 12 weeks. And it doesn't matter whether it's immediate or delayed, you're going to do the same thing. Give them oxytocin, firm uterine massage, life-threatening hemorrhage, drive faster. Get them into the hospital. And then for immediate, again, it's the same thing. Firmly massage the uterus. If she's delivered outside of the hospital, you may want to look down there just kind of externally to see if there's like a vaginal laceration or some kind of a laceration, because that you would want to put pressure on. Oxytocin's not going to help that, right? Oxytocin just tells the uterine muscle to squeeze down and contract. We tell you never to place dressings in the vagina, because personally I've dug a few dressings out of the vagina. People don't know. The only kind of dressing I would ever put in there is a big roll of Curlex, that all of it doesn't go in. And if you do ever have to put most of it in, you put a clamp, some kind of clamp on the end, just to make sure that people don't forget it's in there. Does that make sense? You know, look to make sure she doesn't have anything bleeding, because oxytocin's not going to help if she does. And then again, manage the patient's airway, oxygen saturation, give her crystalloids, and drive faster. Oxytocin here, I went ahead and I printed that out for you. 10 units of IM until you got her in your ambulance, and then you can start an IV. It's not going to hurt to give her the 10 followed by 20 and a liter of either normal saline or lactated ringers. It's not going to hurt to do both. And then if there's ongoing bleeding, then you can give misoprostol. Now, we're kind of walking away from misoprostol a little bit on labor and delivery, but do you have misoprostol in your ambulance? We usually give somewhere between 600 and 800. You can give it orally. You can give it sublingually. I usually give it orally. We've kind of gotten away from giving it rectally. But these are actually what the ACOG and your society guidelines recommended. Blood product administration should be considered, but I don't think you're gonna be doing this in an ambulance. You're gonna hopefully have her on labor and delivery by the time we get all that. And then TXA, how we dose TXA, I don't know if you give 2-gram bolus, but usually we give 1 gram. Wait over 10 to 20 minutes, wait 30 minutes. If she still needs something, then you can give it another gram IV, and we just mix it with a little bit of like 100 mLs. So, but it is possible, and it's not gonna hurt her for you to give the TXA. So in summary, obviously pregnancy-related deaths can happen during pregnancy. After the pregnancy, most of ours in Indiana happen during pregnancy or within the 42-day window, which is kind of historically what the rest of the world looks at. The United States looks at maternal mortality up to a year after birth. Obviously, it's critical because you guys are on the front lines and you're going to see all this stuff. And unfortunately, patients don't come labeled with the diagnosis. And, you know, OBs, well, I know that was that all the time, but yes. Anyhow, it's important to stabilize the patient. Make sure that you understand that our elevated blood pressures, if it's greater than 140 systolic or greater than 90, we're very concerned about that. If it's 160 systolic or 110 diastolic, we consider that a severe hypertensive emergency. And we have protocols that we have to respond within 15 minutes. We have labetalol protocols, nifedipine protocols, and so we have to respond. So we don't hang out and watch these severely elevated blood pressures. I can talk about this case because it was in the newspaper. Greene County ER, lady down there delivered. But then I think 3 to 5 days, had severe problems and symptoms. Hopefully nobody here took care of her. Went to the ER. Actually, because we reviewed that case, I can tell you actually had blood pressures. The highest blood pressure was 188. That was her highest systolic. She ended up stroking in the ER. Stroked and died. So it's not, you know, the 220s that you guys probably routinely see. We don't have that. We don't allow that. We don't want any part of that. Because 160 over 110 usually makes our little sphincters kind of. It's a little bit low. So that's the big thing is our pregnant women have kind of a lower threshold for concern and actually in the postpartum period as well. And that's it. Hopefully we have time if you have any questions.
Yeah, you might have any
Sorry, I
questions?
chatted too much. Yes, sir.
How much value do you put on pre-hospital blood draws?
I wondered about that when I had that up there. I think it'd be good to get that. Now, as far as the quality of that, I mean, does it matter? Do you run it? Does your hospital run it if somebody else drew it?
We do
Yes.
now, yeah.
We do in the ER.
Okay, that's what.
In the ER, the OB, Union's OB is notorious for throwing away lab draws immediately as we
Are
can.
they really?
Absolutely they are.
Sorry, what's that now? I'm sorry. You tell me what you just said. That's the first I've ever heard of that.
Hospital blood draws from the ambulance.
So if you guys show up with a patient and blood in your hand, having said that you all drew it in the field, are you telling me that we are throwing it away when they arrive?
Oh, yes, ma'am. Yeah. absolutely.
Okay. Today should be the last day that ever happens.
Cool.
The dialogue.
Yeah, absolutely.
You know what you all do. You don't know what we do.
That's one of the dumbest things I've ever heard of.
What else?
Why would we do that?
So you don't carry misoprostol, Cytotec. You do carry oxytocin?
No, we do.
No.
No, so
Probably
nice.
You said we should have a conversation about it. You know,
We should have a conversation.
But I mean,
We can
that would be
discuss that in our
closest
EMS
you would have.
advisory. Talk that through. I might get some information from you, so.
The oxytocin is not
To us, or you can come
expensive,
join us
it's
for that.
pretty reasonable, honestly.
Oh, you look.
We meet at 8
Yeah.
o'clock the day,
Really?
you know, people are not.
We have-
like
One-
8 o'clock,
180 for 25 of them?
EMS offer
And that's the unit?
so
You guys.
Yeah, I'll take care of it.
It's optional.
Went on last night.
I'll take care of it.
Lots of home.
I'll take care of it. Yeah, but that's a conversation we need to have.
Yeah.
Is greater than needing the mag. Like,
Yeah.
like
Yeah.
the
I think there's a
I
fair,
think that you have a higher risk of this scenario
Yeah.
than
Yeah.
the seizures.
I agree.
Yeah, we carry mag for other reasons too. so.
Right.
Yeah, you have the mag though.
Yeah.
right? Yeah. Yes, ma'am, in the back, green shirt.
I feel like we've had a lot of pre-hospital babies being born.
Yeah.
We've been talking about, I'm the manager in the ER. If we have a patient that presents cardiac arrest right after delivery, are we to assume AFE most likely is the cause?
I would until proven otherwise, yeah. And the only, I mean, if AFE or not, they obviously don't come with a sticker.
Right, there's no difference in
Treat
treatment
them
or,
as an AFE,
and just CPR.
which is high quality CPR and massive transfusion protocol.
Okay.
Getting it up there, putting it in as fast. Now, do you guys have the tag?
The OR has it, but we can get it. It's,
The
but
anesthesiologist has
Yeah.
to run it. Do they have it in
No.
labor and delivery?
No,
Okay.
no.
I thought it was only cardiac surgery.
I
I thought it was only cardiac surgery.
so we made arrangements through trauma to where if it's
Yeah.
needed, we just call, but they're also part of our response. So anesthesia is already a part of the care when the trauma patient arrives, but it's their. Charlie
So
Cochran
can you
Tasmania.
transport it down to you?
No, they
They have to
they
take it
take
down.
it down and run it.
But if the anesthesiologist is taking care of the patient, how does the anesthesiologist?
The
have
whole
time?
OR team shows up and so somebody, there's usually a CRN there helping aid. Plus we have respiratory and our physicians
And the trauma surgeon.
and the trauma surgeons
Yeah.
and so there are lots of physicians present when we have a trauma. So,
We don't have.
yeah.
Okay.
So someone could take over airway or whatever anesthesia is managing at the time so that anesthesia could go run it.
But only anesthesia can run it here. You don't
Yeah,
Because it's in
have.
the OR.
It's in the OR and it's not cost effective to put it in other places yet. And it.
But when I
from
worked
what
at regional, we had it in the lab and we would draw the labs and send it.
From what
down
I
to
understand
the-
from Dr. Cochran, it's quite expensive and there's a lot of strings attached to keeping that. And I think you have to go through like CLIA in the lab and all that, is that right? Yeah.
I've never had that.
Yeah.
There's a lot of training because it's very operator dependent.
Yes.
Okay.
So I think they wanted.
Memorial in South Bend, they brought it to the ICU. And it was the AFE that took me a little while to figure it out, cardiopulmonary arrest, got her back, took her up to the ICU. All of a sudden, all of her Band-Aids, she's bleeding. So we still didn't know what happened. She just had sudden cardiopulmonary arrest. And then all of a sudden, I mean, my eyes, I was like, I know, what's her coags? And the nurse goes, damnedest thing. I drew them and they said they weren't drawn appropriately. There's nothing there. And the crusty old anesthesiologist, who I probably has a cigar out of the side of his mouth most of the time, he did trauma. And he goes, that doesn't make sense. I'll draw them myself. So he drew them right away. Came back the same thing. They can't detect any coagulation factors in it at all. She had a massive consumptive coagulopathy. And it was then where, I was like, yeah, it was an AFE. She had an AFE. She had just ruptured her membranes in labor, just ruptured her membranes, sat up and said, I can't breathe. Red face, couldn't breathe. And then had cardiopulmonary collapse. But it took me a little while. It was the first one I saw in real time. Anyhow, but yeah, the only way they're gonna survive that is very high quality CPR and a lot of blood products. And you just keep dumping the blood products in. The tag helps you determine, do I need more cryo? Do I need more platelets? What do I need more of? And so it was wonderful and Memorial had it there. And that was the first time I encountered it. All right, any other questions? Yes, Kristen.
I don't have a question. I'm just gonna add, I think you said it, I think I counted 5 times, but it's worth saying a 6th. One of the most important things you can take away is any woman of childbearing age, ask her if she is pregnant. If she's unresponsive, ask the people around her if she's pregnant or if she has been within the last 6 weeks. So many times we reviewed a case of a maternal mortality And, you know, that question, it's in the ER record, right? And it wasn't answered, or maybe people just kind of clicked no, right? Like, we get into these methods of just kind of, oh yeah, she's not pregnant, because you don't see an obviously like gravid abdomen, right? But it's just so critical that a huge takeaway is pregnant women are not quote unquote normal women. And what you see in their blood pressure, we treat drastically differently than you all would treat. And we see things very, very differently in pregnant or recently postpartum women. And so many times we saw that a woman had been in the ER once, twice, 3 times, had been in convenient care, had been in primary care. I'm not feeling well. And we kind of denied or delayed and said, you know, oh, well, I mean, if there are any women or men even, right, who've ever had a newborn in their home, how do you feel? You feel not quite right. You have a headache. You're not sleeping well. You don't feel like yourself, right? So we often just kind of pass these symptoms off as, well, they've got a new baby, when in fact she's about to have a stroke right in front of your eyes. So being so in tune to women of childbearing age, are you pregnant or have you been in the last 6 weeks? And just understanding that we treat those patients differently. Their blood pressure is not the same as a non-pregnant woman. Their signs and symptoms you've got to take differently, because they are different, and they could be screaming at you that they're near a huge event.
I also want to talk about the ruptured ectopic pregnancy, the one we reviewed last month. Patient was seen in the ER, had a beta of, I think, 4,600. They should have probably seen something in her uterus, or they should have probably known. She wasn't having any pain at that time. Told her to follow up in an OB's office. She didn't have an OB. Told her to follow up in the OB's office in 2 days. She didn't have an OB. Have any of you ever tried to call a new OB office and try to say, I'm sorry, I need to get in within 2 days? That's not gonna happen. She ended up dead on the 3rd day because she couldn't get into an OB's office. So we routinely would bring them, hopefully, I think Mike Allen does it pretty well, brings them back to the OBDD. Yes, they're gonna incur an extra charge. Yes, that's a problem, but it would have saved that woman's life. She did.
Did she have an ultrasound?
She had an ultrasound, didn't find anything in the uterus. And at 4,600, you and I know,
Right.
you should have found something. This was in Indiana. They just said, follow up in your OB's office in 2 days. She couldn't get in and ended up dying. So I would be more lenient with that possibly crazy woman who shows up all the time. And, you know, just have her come back to your ER or somewhere where you can reliably get her in. In the middle of the night, you can't even call Grant Hammonds to say, can you see her in your office in 2 days? Because she's going to be stuck with the call center. Talk about, yeah. Any of you have ever tried to call it yourself? Right. She can't get in, and then there'll be all these Cerner messages about where can we put this lady, or how can we get her in, blah, 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 blah. Now 3 days have passed and she's passed away. So you gotta be a little bit lenient. If you can't find it in the uterus and you know from your training that you should, bring her back to your OR, ER, sorry, long night. Bring her back, because they can and will die. And we had one, we have another one this month. We usually have, unfortunately, a lot of ruptured ectopics, which is kind of scary to me. All right, that's all. Do you have any other questions? Thank you for listening to me chatter. I appreciate it.
Thank you. Boy said EMS, there are two of the most critical, true EMS emergencies: ectopic pregnancy and severe anaphylaxis. And that I tell them, basic EMTs, Matt, I've told this guys, everybody, those are the 2 emergencies that just absolutely true emergency. All right, guys, here's a code for you to sign in, or you can use the link to get credit for audit review. Next audit review will be the 2nd Tuesday in November at Regional. Any questions at all? If you guys need something, those are going to be out at EMS World next week from like Tuesday through Friday. So if you need something, you need to get with us before the end of the week. But I'll leave this up there for a while. Thanks for joining. Thanks again, everybody, for presenting. Appreciate it. Have a great day.
Do you think we need to have, I don't know how busy you guys have been, do you think we need to have some sort of surge? Like, have we ever talked about it?
To where he would need to start planning, but. Did Gina tell you what?
Mm.
We said we like stupid ones.
One of my chargers star with Craig. We went and checked in and Gina handled this. She went and checked in and they said.
Is she here?
When she had been in Craig, her foot back in and stuff, like she was pretty solid.
Oh, is she new?
And they said, we're full right now, but if you go have a seat in the lobby, we'll be out to get you. They didn't take her name, which Gina was like, that's a problem and fix that. But I was like,
Nothing, dude.
if she was fully,
Thanks.
stressed,
Reminds you.
she had been pointed back. You know what I mean, versus
Yeah.
sit in the lobby. I didn't think that ever-
Yeah. They offer her a full-time position.
So I'll get Robbie like, hey, very good.
Hospital instead of for the.
Like, really? Yes, everybody.
Yeah, exactly. They gave her 3 options.
Okay.
Yeah.
And she,
One was like
she was like.
high.
What?
You've done a tree on
Yes.
Lower
And that's.
dollar per hour with no benefit.
And I was like,
Yeah, lower dollar per hour.
the time before she came in, a couple days prior. And they did take her name. She-
Cause I like to.
And out later, she said about an hour later.
Yeah, I like.
Get up and.
Chill out.
Yeah, get up.
2 days.
I mean, it sounds like they're gonna.
Yeah.
Not a great perspective, you guys are dad.
Find out.
Yeah.
Let me talk to Gina about it, because I don't know the answer to your question yet, but I.
Yeah.
Yeah.
I mean, that way we
Looking
did.
at it.
They very helpful, it's like we do, you know.
Think about doing the. I mean, we did work out schedule anyway, just think about it like.
I told this, he's just showing, where he goes, that makes a lot of sense.
Yeah.
Tolerance for people who are.
But I mean, it sounds like they're gonna.
My finding.
But there's some in there that like were obvious, that
Yeah,
things like that.
I think she's waiting for them to answer some more questions.
So just wait. If we have. If we have you sign off on. And just. Okay.
Yeah, I hope so, man, that'd be awesome, yeah.
So there's just different things.
No, I remember specifically one time coming in there like 2 in the morning.
We'll make-
and had his